Talk to us about total endovascular repair for chronic type B dissections.
Thank you, and it gives me great pleasure to have some time at the podium again. And it really is nice as I think back in my own career, almost 2 decades, the evolution of endovascular therapy towards aortic dissections, how now it's matured, and we really see or understand that chronic and acute dissections are really different animals. And perhaps in terms of the analogy of apples and oranges, it might be apples and bananas, something really different. The subject of my presentation is really focused on chronic, and I want to emphasize chronic. It's got nothing to do with acute, and anything I say has absolutely no application to the acute or even subacute phase. The principles of therapy are outlined here, and the previous speakers have also alluded to this. The therapeutic goals are exclusion and thrombosis of false lumen. I think everybody agrees with this. Positive remodeling, prevention of ultimately dilation and the real complication of rupture. Prevention of late complications, residual dissections such as redissections, which can also occur, and sign, as well as preservation and restoration of essential branch perfusion in cases of malperfusion syndromes. We would also like to affect closure of the proximal or so-called primary entry tear, and however, we do recognize that alone is insufficient, and ultimately false lumen exclusion and total false lumen exclusion, not just partial. What do we know about the natural history of this progressive enlargement? Although the actual rupture risk of this subset of aortic disease still remains somewhat poorly defined, the tensile strength of the dissected aorta, and this is somewhat controversial, how does that compare to that of the undissected but aneurysmal aorta? Persistent patency of the false lumen, redissection, loss of septal plasticity, which Dr. Criado just alluded to, and this issue of healing or the stenosis or closure of these visceral reentry or fenestrations can also pose a problem in the context of endovascular therapy, perhaps not so much in open aortic disease. Some of the natural history has been studied in this select group of published works. One published work describes a systematic review of midterm outcomes and over 500 subjects with a median follow-up of almost 3 years, and they described this phenomenon of the residual distal aortic dilation in approximately 8% of patients. In another study of late aortic remodeling, and they talk about the unstented segment after simple thoracic endovascular repair of the thoracic segment in over 80% of the subjects, with an average diameter increase of 18%, and it is associated once again with false lumen patency. In another paper, there was almost a 9% rate of reintervention for aneurysmal degeneration at 3 years. Several treatment strategies have come about in the last 5 to 10 years in terms of how to deal from an endovascular standpoint of chronic aortic dissections. And I've outlined or condensed these treatment strategies into 4 different buckets. In the most simplest sense is the endograft closure of the proximal entry tear. And on the right-hand side of the screen is what my personal opinion, this is one man's opinion, of how effective that strategy is, and I colored it in red. I actually think it's completely ineffective and has no role in the setting of chronic aortic dissections, not acute, but chronic, because it incompletely excludes the false lumen, and it gives a significant risk of sign. The second strategy is endograft closure of the proximal tear, as well as all descending thoracic aortic reentry tears. Again, just isolating the treatment to the thoracic segment and forgetting about the thoracoabdominal segment. And in that sense, that treatment is a little bit better than the first treatment, and it deserves a yellow color with rare and occasional false lumen exclusion, but also giving the residual risk of a sign. The third strategy is endograft closure of the proximal entry tear with all descending thoracic aortic tears, so it incorporates option number 2, but as well as selective closure of individual abdominal iliac reentry tears. And the benefits of this is potential false lumen exclusion, decreased spinal cord ischemia risk because you're kind of point welding all